right, good morning, happy Monday. And today we have a very special guest, Dr. Robert Riviello, who will be given a very formal introduction in a couple of minutes by Dr. Nguyen. The genesis of this lectureship, it's named in honor of a former resident here at the University of Colorado, Dr. H. James Fox. Dr. Fox was born in Dallas, Texas, and then went to Dartmouth as an undergraduate, and then went to Dartmouth Medical School. After graduating from medical school, he came here to the University of Colorado and did his internship and then 2 years of his surgical residency. And this was in the late 60s, and he was actually drafted into the Army. First went to a base up in Massachusetts, and then was actually sent to northern Thailand. And I try to put things together. I think we were actually in northern Thailand. My family was there at the same time he was there, and I think at the same base. He was there for a very short period of time, and became very ill, was evacuated back to the States, came back to the University of Colorado, and was found to have a leukemia that was very, very aggressive, and he quickly died. And this lectureship was built in his honor by his wife, his family, and his friends. And we're very lucky to have Dr. Riviello here to give this 14th annual lectureship. So before I turn it over, I want to congratulate Dr. Nguyen and Dr. Gibbs for all they've done, along with other faculty, to really bolster our global surgical programs. And this is something near and dear to my heart, given my background and my travels and living overseas. And it's something that I think we owe the world and society in general. There's a whole program laid out for today, and Dr. Nguyen can go over those details with you. I'm going to ask you to come up, Fong, and take over the honors here. Thank you very much for all you've done.
Well, thank you very much, Dr. Schulich. It really is my supreme honor and pleasure to introduce our next speaker, who is the inaugural Global Surgery Visiting Professor for our inaugural Global Surgery Summit. So Dr. Robert Riviello did his undergraduate degrees at Harvard and his MD at UCSD. He subsequently received an MPH in Population and International Health at the Harvard School of Public Health, and did his general surgery residency at Vanderbilt. Subsequently, he did a Fulbright International Fellowship in Angola in global surgery, and did clinical fellowships in both acute care and burn surgery, as well as critical care at the Brigham. He's been on faculty at Harvard Medical School since 2007. Since 2009, he split his time in Rwanda and Boston. He's a professor at the University of Global Health Equity in Rwanda. Currently, he is the Kletchian Distinguished Chair in Global Surgery at the Brigham. And he's the director of the program in Global Surgery and Social Change, or the PGSCC, since 2023 at the Harvard Medical School Department of Global Health. This is really one of the premier programs in the world when it comes to academic global surgery, and has really pushed the field forward. He's on multiple global surgery grants, including the NIH, including 3 R21 grants. He has over 140 publications. And I think most importantly, he is a mentor to countless number of trainees and now surgeons around the world, and really is widely regarded as one of the best human beings that you'll ever meet. So it is my honor to introduce Dr. Riviello. Thank you.
Well, good morning. Thank you, Dr. Schulich and Dr. Huang, Dr. Gibson, and the whole crowd here. It is an absolute delight and a pleasure to get to share some thoughts. I hope to have some interaction for those of you who can join the Global Surgery Summit later today. looking at the program that Cameron's put out, I think it's gonna be a terrific multidisciplinary interaction. Some talks, some quick shots, and some engagement interaction. Let's see. There we go. No financial disclosures. When we first started talking about this conference was back in the fall, and said, great, that sounds terrific. Looking forward to it. I'm so excited about what is going to happen here near Chicago in this launch. And we have to recognize, I had to recognize that things have dramatically changed in the last, this present moment is different than the present moment was back in October. And I'm not going to belabor this, but public health has changed. Our US relationship with WHO has changed. We've abolished we've essentially abolished USAID, and with all of these changes, it's not like any of the previous structures were perfect. I had some conversation last night about very inefficient use of USAID funds previously. And in the last month, there have been times where there's been needs for major humanitarian engagement, both in Myanmar, less known, but 800 burn victims in Iran just last week or 2 weeks ago, where major international aid would be helpful. Every university is feeling this, the NIH cuts. My own university is somehow the David and Goliath story at the moment, taking on the US government, taking them to court. And then just last Thursday, I think, so less than a week ago, the NIH announced that there would be no subcontracts to foreign subcontractees, i.e. all NIH funds have to be spent essentially here in the US and for people only here in the US. So people started asking, will science, not just global health, but will science survive this time? So I say all these things not as necessarily a downer, but to recognize present moment is a challenge. And as we talk about global anything, health, surgery, anesthesia, obstetrics, just want to see this in this moment. However, my objective isn't to belabor all the downstream effects of these major geopolitical changes, but to talk about what is global surgery. Okay, we kind of look at those words and say that sort of makes sense. Probably surgery somewhere else. What are the principles behind? Maybe a more robust sense of that. And then the next ones are sort of self-reflections of in some sharing of examples of programs from experience of the program of global surgery, social change, University of Global Health Equity, and I think what are some future opportunities. So let me start with that. Global surgery has been variably defined by lots of different folks, and it was tried to create a definition that wasn't just, quote, international surgery, us in the global north going there to somewhere in the global south. I recognize that to deliver surgical care, you need lots of things. And so it's a burgeoning field that's, I'm biased, of course, but pretty exciting. That is study, research, practice, advocacy, policy, that is by definition multidisciplinary. We get the sense of that, right? Anesthesia, obstetrics, nursing, surgeons, physio, all needed for good surgical care delivery. It's also multi-sectoral, right? You need to have water and power and infrastructure and transportation to deliver surgical care for a population. And it has a focus on vulnerable populations, those in crisis, those on the margins. So as of definition, this is what we mean by global surgery. Many of you will probably be familiar with this map or similar maps, heat maps like this. This was from the Lancet Commission in 2015 on global surgery. And the darker the red, the less likely you're going to have access to surgeon, anesthesia, obstetric specialists. So there's great variance across the world. But in the public health sector, surgery is still sort of discussed or felt to be, it's long been felt to be this sort of luxury. We need vaccinations and we need water and electricity, and all those things are needed. But Also in public health, people get injured because they have to get to work, and usually they get there by some kind of motor vehicle. People, they're surviving infectious disease, and so they develop non-communicable diseases like cancer. Children are stillborn with congenital malformation problems, and there's still a lot of complications in pregnancy. And all of these need the act of an operation, a surgery, but they also need healthy, functioning surgical systems. So in 2015, I'm going to review this a bit. I realize 2015 is 10 years ago, and we're conscious that we're on the 10th year anniversary of this. The Lancet Journal published the Lancet Commission on Global Surgery, otherwise known as Global Surgery 2030, which is where the title of my talk comes from, which was intended to do a number of things. It utilized a very broad base of experts across all those disciplines that I've mentioned a few times, from all the continents except for Antarctica. Something about 110, 120 different new articles, peer-reviewed articles were published, not in the Lancet, but in a host of journals looking at different pieces of the surgical healthcare system delivery. And then those lessons learned and observations and expert opinions were consolidated into the Lancet Commission, which had 5 key messages, 6 surgical indicators, and then a framework for how to move forward to give recommendations to countries. And I'll touch on each of these very briefly. A lot of this was modeled data, but the idea was to give a sense of the magnitude of the need or the opportunity in a world that then had 7 billion people, 5 billion people lacked access to surgery. And by that meaning access to surgery when you needed it, surgery that was safe or quality, and surgery that you could afford. And that there's really surgery, obstetric anesthesia access. If everybody got the surgical care they needed when they needed it, that would prevent 17 million deaths a year. That's in a world that already has about 15 million deaths. So about a third of the world's deaths were surgically related. And then consequently, about a third of the world's global disease burden relates to surgical care, which was new at the time. That was not known. And if the needed surgical care happened, that would save the world $12 trillion. It's really kind of hard to wrap my head around $12 trillion, but our US wars in the Middle East cost us about $1 trillion. So just to kind of get a sense of where that fits. Again, that's mostly model data based off of the best information they had at the time. And then in trying to provide some recommendations, some guidance, the commissioner structured the recommendations along this sort of continuum of these 6 pillars of care. And if you look at them, this is what we do. Maybe not each of us as an individual, maybe not each of us as a department, but even just as a hospital system, we do all these things, right? We develop workforce, we provide service, we keep data in our patients through electronic health records, through registries, through quality improvement initiatives, through research. We're constantly building because we need more space to provide the care. We have to figure out the financing, and then there's got to be ways to govern. So strategy, planning, decision-making. And that collective was organized into what they refer to as the national surgical plans. And I'll come back to this in a bit. But national surgical planning required really all those 6 pillars, and those reflected their World Health Organization recommendations for the pillars of healthcare planning. And then the Lancet Commission also came out with some essentially positional statements, or they're a little bit beyond philosophy, but these are agreed upon beliefs that investing in surgery, I told you $12 trillion, is affordable. Even though surgery seems like a luxury, it's actually fairly cost effective to deliver. It saves lives and promotes economic growth. And hence surgery is indivisible, indispensable part of healthcare. We get that here, but at public health tables, surgery was seen as other, as bringing these 2 pieces together. And then the positional statement, the vision statement that there should be universal access to safe, quality, affordable surgical care when needed. So that is what, if I was to give, that's the 3-minute primer on what is global surgery. When we're organizing this conference, it seemed to me that what are the principles around it, right? I gave this definition that was much more than doing surgery somewhere else. So what are the principles of global surgery? How do we comport ourselves? How do we organize our activities or our thoughts? When I actually creating this slide back in the fall, I was kind of a bit of a Luddite, coming a little late to AI and ChatGPT, and I said, let's see what ChatGPT has to say. So I just asked ChatGPT, what would you say are the principles of global surgery? And it gave me these 7 principles: equity and access, affordability, financial protection, quality and safety, workforce, infrastructure, data, sustainable partnerships. And I was struck that actually almost all of those were back in these previous slides. Here and here gave me everything except for discussions of equity and discussions of sustainable partnerships. So I'm going to talk a little bit about both of these before we get into other programs. So it turns out this is a bad word now. And there's I can say that tongue in cheek, but there actually is the real pressure to start scrubbing our language. So equity essentially is justice. It's fairness. It's making right imbalances that were there for human created reasons. So I use the word justice all the time, but I think I'll probably stick with our word equity because it means something to us and words have meaning. But to understand equity, I think we first need to understand a bit of history. A colleague of mine, Dr. Barnabas Aliande, was the first one to pull up this slide and point out that the notion of independence, colonialization, essentially every country or every land mass and every human population at some point in its history of the world has been conquered and colonized by another foreign group of people. But the question is when, what time in modernity versus pre-modern history? And so if you look at the map and you see the modern day independence, right? South Asia, most of Africa, Southeast Asia. And then you compare that to almost any map that looks at human workforce in healthcare, that looks at access to vaccinations, to essential medications, to any piece of surgical care, any piece of healthcare, there is a stark mapping of the color codes. So this is anesthesiologist density. Surgeon will be the same, nursing's the same. The hottest spots are the places that have had the least amount of time to develop without colonizers. So there's a question of equity. When we look at what is global surgery today, I think we also have to have the same humility in assessing what is it that we're doing. So our roots, our own historical roots, is really tropical medicine. And tropical medicine wasn't designed to improve the healthcare of what we now refer to as the global South. It was designed to protect European colonialists and US colonialists in tropical areas. So understanding malaria and yellow fever happened to allow the Panama Canal to be dug out, or Africa to be colonized, or South America to be colonized. This over time, humanitarian medicine came through, right? Doctors Without Borders, medicine otherwise known as Médecins Sans Frontières, etc. Humanitarian medicine largely happened during the Cold War. Has obviously a more humanitarian bent to it. We developed international health, again, that sense of global North going to global South places, rich, poor, and then global health. And I think the architects of that change from international health to global health intended for this to be not about a here or there, but about a partnering and accompanying the vulnerable. As we say in Boston, Mattapan and Dorchester are on the globe. And so, however, that architecture didn't really carry out. And there has been, I think importantly, over the last several years, a movement to, quote, decolonize global health. And some of my, again, colleagues that some mentioned already, some I haven't, Abebe Bekele, Barnabas Aliande, have asked, well, is that really is decolonizing global health what we're looking to do? Or are we looking for something more transformative? And so decolonizing health versus equity. Decolonization, does some important things, right? It recognizes power dynamics. It recognizes that there needs to be a changing of the structures. it speaks to racism and supremacy, and it sort of requires a dismantling of structures that have kept groups separated. But it's still a dismantling. And so in the dismantled space, what are you going to build there? And that's what what equity emphasizes. It looks at access to care and education and quality. It has a tomorrow vision. So that's a few reflections on equity, not so much what needs to be scrubbed, but what it means for us when we engage in an equity agenda in the work we do in global health. Partnerships. This, I think, is essential to the former and essential to all the work we do. But what do we mean by partnerships? We use these words, acquaintances, collaboration, partnerships in lots of ways, but most of our engagements, I would say, and this isn't a critique, it's just a recognition of real relationships. Most of our human relationships are not a partnership, not something that we invest in and we commit to for long term. But a few are, and these long-term continual engagements, I think, are essential to impact over time. So partnerships have the potential, start with the win-win. It's not what do I have to give you right now? It's how do we work together? It takes away that debtor-creditor relationship, or at least it looks at it, recognizes it, and says, how do we dismantle that and lead to a work where we are working together with the aim to improve access and quality. I'm going to borrow this metaphor or this parable from Prof. Navajit Roy. Dr. Roy's been lots of things, 20 years, a general surgeon in Mumbai, then an attaché to the health minister of India, 1.2 billion people, then worked at WHO. He actually now works in Rwanda with the University of Global Equity. But in 2015, Roy gave this talk. We all know that the parable of, give a man a fish, you'll feed him for a day. You show a man to fish, you'll feed him and his family for a lifetime. But then they said, what if the man is a vegetarian? What if he doesn't like fish? What if he's had a liver fluke and he never wants to see a fish again? Let's find out if the man and his family eats fish before you teach him to fish. And if he does fish, maybe he already knows how to fish. Maybe he fishes in a river and you fish in an ocean. Let's figure out together, where does he fish? And what's the fish there? And so then Roy's call to us is, don't give him a fish, don't show him to fish. Go fish together. And that way your fishing's gonna be more fun and probably more productive as well. So that's the fishing principle. At UGG, we use a number of these different frameworks for how to think about partnership. This is the Monet principle. She published it in, I think, 2020 or so, 2021. These 5 major categories, which are kind of, in some sense, all incorporated into the fishing parable. Partnerships should be actually mutually beneficial. The agenda setting should happen together. We keep each other accountable, and they should have this focus on building capacity. Makes sense, takes time to do that, takes conversations that are real relationships. It turns out, though, we don't just have to keep our view within healthcare to understand partnerships. So if you look at the attestation, this is from the Journal of Tourism and Hospitality. Actually, before we started talking about equitable partnerships very, very deeply in global health, and it's the fair trade rubric. We've all probably bought our fair trade foods, but the fair trade rubric includes a very robust framework of looking for common purpose, leaning in on community program leadership, locally sourcing, right? This is the fair trade principle, making sure that the host community is not just observing, but is actually participating in the process, that there's transparency. We know where the money is coming from and where it's going. Budget transparency is not a thing we do very easily. Always being conscious of the rights of the vulnerable, communicating clear lines of communication between the partners and, frankly, the host community, recruitment locally, social media that benefits, frankly, all actors, but principally the host community. Partnership, i.e. long-term engagement, not just program. Clarity of commitment, evaluation of partnership. This is the QI metrics come back and how are we doing? Let's have a measurable rubric. And it's funny, this is the last one. The theory of change actually needs to start at the beginning. What is the change we want to see in the world? And then work our way backwards. How do we think we can get there? And that then provides a structure for evaluation. We've simplified this for ourselves at UGG, which is sort of a merge of the previous two. And it mostly is carried here, that equitable global health partnerships can only be achieved by care and respect, but then leads to mutual dialogue. That takes time. Finding activities where we benefit each other mutually. Developing trust probably should be the first bullet point. That's how you get there by mutual dialogue. Good communication practices and continue reviewing. Do we drop things? How can we communicate better? Clear partner roles, expectations, accountabilities, and endpoints, maybe not to the partnership, but at least to each project together. So a framework for equitable partnerships, which as the last couple pieces of principles of how we should engage, I think, in global surgery, in global anything, right? Fair trade, global medicine, public health. So the next section is current programs. When Dr. Fong and I were talking about this conference, this day, the interchange later today with actors from and folks from all over the University of Colorado system, it struck me that the exercises you'll be doing today are actually very similar to exercises that we were asked to do last fall. Some of you may know that the hospital I work at, Brigham Women's Hospital and Mass General Hospital, we're kind of going through a merger of sorts, but as an integration, we're calling it MGB. And I was essentially asked to map out all the global surgery activity across the Harvard space, or the Boston apparatus, as my Rwanda boss would refer to it as. And that's a lot, and I won't go through all the Excel spreadsheets that included, but it essentially boils down to a bunch of agencies, some hospital-based, some medical school and university-based, and some peripheral but adjacent NGOs and other labs. And it looks something like this Venn diagram, where at the medical school we have connections where the medical school is connected to all the hospitals, but there's some established global health leadership and research expertise and epidemiologists, public health providers. At the hospitals, we do things like provide care and train residents. Frankly, most of our PGC faculty are clinical, and so we're hospital-based, and so we run all of our IRBs and our grant through there. And then this sort of third bubble is the broader community, the global health institutes and the laboratories that are nearby, the NGOs like Partners in Health. So across these, there's some subject matter expertise. There's a history, various histories of collaboration that are worth investing in. I think that's part of what's going to happen today, and it's something that I would encourage University of Colorado to do, to kind of find where those interlinkings are in your own local landscape. I've benefited a lot from the ID folks and the non-communicable disease folks in terms of how to move along surgical programs. I want to give a shout out to the PGC trainees. PGC, again, is Program in Global Surgery and Social Change. These are research fellows and research collaborators, which are essentially medical students on gap years. I know there's a incoming first year research fellow for this year that I look forward to meeting you. So the research fellows are many things. They are learners, they are force extenders, they're doers. They're given a fair bit of agency, and sometimes that goes great and sometimes that doesn't go great, just like in residency training. And so we need to supervise our fellows, but also give them some leash, some rein rather, to make partnerships, to develop trust, to have those conversations, to envision with collaborators at our global sites. So I told you I'd come back to this. We're not going to go through a national surgical planning exercise, but I was struck by this super simple framework of 6 different things. As I mentioned in the beginning, these are all things that we, as divisions and programs and departments and hospital systems, engage in. And at any individual stage of career, you're going to be engaged in not all of these, but a more select set. But I also think each of these forms a sort of entry point for us in global health. If you as an individual or as a program are looking to be engaged with partners overseas, what's that activity going to be about? Is it going to be about workforce, service delivery, governance, financing? And so I'll have some examples of many of these, but these have been for us various entry points into engaging in global health work. So this is a list of various projects. So this is within the Boston apparatus in its partnerships in different places. START is probably one that would feel very familiar for in a training setting. So START stands for Surgical Techniques and Repairs and Trauma. It is essentially a modification of a couple different ACS courses, the ADAM course and I just blanked. ADAM and two different cadaver-based, one pig-based, one human-based, cadaver-based course for teaching surgical access in trauma, right? If somebody has a penetrating injury to your subclavian artery, that's a tough one to make it a resident teaching case. First get proximal control here by cutting in this place. You can't do that because the patient exsanguinates. And so the START course is intended to teach all those maneuvers, proximal distal control, how to manage vascular injuries, how to manage other major trauma injuries in the pace that's needed, right? It's simulation. And it was designed first with colleagues in Uganda, and then modified with colleagues in Haiti, and then modified again with colleagues in Rwanda. So the general curriculum the core parts of the curriculum have stayed the same, but with each new location and each new set of partners, the epidemiology is different. Trauma in Haiti is very different than trauma in Rwanda. Trauma in Haiti in 2000 is very different than trauma in Rwanda in 2000, right? Context matters. Context matters both geographically and chronologically. And so the Rwanda-based startup course, which had its first run a couple years ago, and that was training instructors and engaging with instructors, the Rwanda national surgeons, they modified it for their next rounds as they were teaching it for University of Rwanda residents to focus on more of the trauma that they're seeing, which actually is much more extremity, and the vascular is usually secondary to orthopedic injuries, very little penetrating trauma in the country. So these slides represent some of that working together to understand the needs assessments. And it can be done in partnerships with universities. This is at University of Rwanda Medical School in the cadaver lab, the anatomy lab. And it did more than elevate or provide a course, right? Your HLS course, your ADAM course, for Rwandan residents, which it did do, and did more than give the instructors a few more skills, both in instruction and in technical skills, which it did do, but it also elevated and reinvigorated the anatomy lab of all things. The professor of anatomy there, I've known for a long time, Prof. Kashegu, he's been teaching first year anatomy for 30 years. Now, as a result of this course and other partner courses, they've created a flight of surgeon-focused simulation courses using fresh frozen cadavers. They've figured out their supply chain to teach flap courses for plastic surgeons and thoracotomy courses for general surgeons with the view towards creating thoracic fellowships, et cetera. And so with each of these interventions that can certainly look like and can remain a very discrete intervention, look for opportunities to broaden the benefit of that intervention. So that's one. Teaching, simulation, close to home. It's what we do all the time. You can look broader. So the photo there is Nicole Reikar. He is a trauma surgeon at Brigham, was a PDC fellow when he was a resident. He was really taken by this notion of blood deserts. This photo is from Turkana County in northwestern Kenya. And there's not a blood bank anywhere near here. The next blood bank is several counties over. So there's really not an effective way if you're hemorrhaging from trauma or from peripartum hemorrhage, or if you're a child with severe anemia from malaria and sickle cell disease, to get blood in the standard way. So the group of them, not Nicole, not just Nicole, but Nicole is my colleague at Brigham, have together developed the Blood Desert Coalition. And this is, the ideas here started actually in rural India with RC, with the Association of Rural Surgeons of India, who similarly couldn't get blood products for their patients. Actually, they promoted a lot of these ideas. That little walking person is human blood banks or walking blood banks, i.e. register people in your community who are willing to give blood in the moment, and when you need it, you call them. Turns out that's illegal in India at the moment, mostly because of concerns of just transfusion-related infections and how to control for that. But then the RC surgeons have said things like, well, if we don't give them the blood now, they're dead today. If we give them infected blood, they might live 20 years before they're dead then. So many of them have actually engaged in this activity for the passion of the care of their patients and spent time in jail as a result of it. So the Blood Desert Coalition has said, can we create the evidence base? Can we work with the blood banking institutions? Can we find point of care test? Can we demonstrate the point of care testing works for hepatitis, HIV, et cetera? Doing all these things to make surgical care safer for patients and surgical care safer for surgeons. So they're focusing on three things. The walking blood banks, I just kind of gave you the idea of it. Autotransfusion, that is probably the most familiar for us in these environments, but it's not just for cardiac surgery, and doesn't necessarily require a perfusionist on site, because that is a health profession that doesn't exist. We don't have cardiac surgery. They're very simplified pumps that will filter blood of debris and can auto-transfuse back in. And the last one is a drone. So drone-based delivery of blood is a remarkable possibility. I've probably one of the first places that this has started is actually also in Rwanda. It's not really not-for-profit. It is a for-break-even, for-profit company that has started drone-based delivery of blood and other medical supplies, mostly blood, all around the country. And you'll see these drones. They're planes about my height that will fly over the hospital. You can see the green light if they're coming towards you and the red light if they're going away. And they'll drop a parachute box. They're incredibly accurate. It'll land in a lawn about a third of the size of this platform. Deliver the blood products as needed. Order it on an app. And they can cover the entire country now. Actually, they're a company that comes out of Silicon Valley, and they're trying to figure out their own financial mechanism. And it's been recognized that you can use the same mechanism for delivering your pizza if you don't want to wait for the DoorDash to get stuck in traffic. So that's some creative financing. They're also trying to make sure that they stay close to mission. But the Blood Desert Coalition is another way, or this sort of activity, using research to support frontline workers and vulnerable populations is another great way to get engaged in surgical care. I've been engaged with the University of Global Health Equity for quite some time. UGHE is a university that first started, it's a university in Rwanda, first started about 12 years ago, really as a master's program. And you can run a master's program, even before COVID, you can run a master's program with just a Wi-Fi connection and laptops, and you bring in your instructors and you provide assignments, and maybe you need a boardroom style room where everybody gets together from time to time. And that is how UGHD started, the Masters of Global Health Delivery, which is the MGHD. I'll come in a bit, but MGHD is essentially a little bit of MPH, a little bit of MBA, a little bit of public policy, kind of all merged together to help healthcare providers, be they doctors, nurses, veterinarians, et cetera, become leaders in their field and change makers in their space. UGHE launched a medical school in 2018, and in 2020, I joined these folks as those medical students were about to enter their clinical clerkships. Photos on the bottom, the one closest to me is Dean Abebe Bekele. He's a general and thoracic surgeon from Ethiopia. He's the dean of the medical school. Barnabas Aliande, I mentioned him before. He's a dear friend, came to UGH actually as a fellow of the program in global surgery. He's now in faculty there. We've worked together for a long time. So our activities there have been a number of things, and I'll just touch on each of them briefly. We developed the Center for Equity in Global Surgery, which essentially is an analog at UGHE, sorry for that alphabet soup, to the Harvard Program in Global Surgery, or the PGSCC, which has a number of pillars of activities. I think the thing we most focuses on is our people. This is an ongoing theme. So the CEGS has folks who are clinical faculty, who are postdoc researchers, who are administrators, who are partners from the Harvard PGSCC. There's a fair bit of porosity between our organizations. Some of our activities have included in that Master's of Global Health Delivery, as I mentioned. 2 years back, we started a track for global surgery. And this is a program that already had tracks in health management, in gender, sexual, reproductive health, and One Health. So global surgery was the fourth of these. We intended for them to gain a number of things, or the big picture knowledge of the advocacy and policy efforts, the Lancet Commission, other things at the WHO, but also practical community-based approaches, practical hospital-based implementation plans. And so UGHE understands the classroom as a threefold place. The classroom is, the learning environment, is the classroom, like this, the hospital, where we deliver care, and the community, not only where patients come from, but also with whom we engage to deliver excellent care. And so students get exposures to all those things. There is classroom-based lectures, debates, discussions, local experts, international experts, in person and virtual. There's also working with the Batara Level 2 District Hospital, which is across the valley, on QI initiatives around surgical care. And that could be actual surgery or anesthesia or physiotherapy or et cetera, infection control. And also community engagement. And actually just last week, the current cohort had their one of 2 different community engagement weeks, and that included both service and survey, if you will. So there was case finding, essentially being out in the community, talking about goiters and talking about fractures and talking about the things that the hospital can provide, and lots of folks show up. And also some education. In this case, it was a breast cancer campaign that we're contributing to, but also survey. So University of Global Health Equity is starting an HDSS, a Human Development and Healthcare Delivery statistical survey. So for the district that it serves, these are household surveys of what kind of conditions do people have at home? And these are at first verbal, but HDSS have been used in lots of different areas in low-income countries, mostly to track infectious disease things, TB, malaria, HIV. We're using it as a whole health system set of questions. So there are surgical-related things and obstetric-related things and general medical things. Our hope there is not only to kind of know what the epidemiology is, but to be able to track, did we make an impact in our community by beefing up surgical care? So about beefing up surgical care, I mentioned I started at UGHE when the students were about to enter their clinical clerkships. And we needed a curriculum, and Abebe, the dean, I said, great, we'll find some curriculum, adopt it. And he said, actually, I think we need to do that more thoughtfully. And more thoughtfully means more time and more work. And so I sighed a little bit. But Barnabas then led us through a Delphi process, getting expert opinions serially over a 5-round process from around the continent, both surgeons and general practitioners who provide surgical care, because that's what our students are going to become when they graduate initially, on what are the content they need, what are the skills they need. And so that process took about a year, and we finalized it together with the University of Rwanda. So we had a harmonized curriculum across the country. And then it was the process of delivering it, i.e. teaching students. And this is still a work in progress, but our intention is to train students in rural settings where vulnerable patients are to understand how do I creatively deliver care at the district hospital in rural areas. This is actually not so easy to figure out when, even though the university is far up in a northern rural place, there's still the constant drawback to the capital. There's the constant draw to the expertise and the kind of ephemeral things that happens when your lecturers are from Harvard and University of Toronto and other places. And so we are still working on how to both integrate the principles of social medicine and commitment to your community with excellence, with the linkages to the broader world. We're still working on this, and it's a year from now. We're working towards starting a general surgery residency that will work at both Batara District Hospital and Kibagora District Hospital, where Dr. Gibson has spent a lot of time, with the same ethos of training surgeons who will stay in those environments and also be leaders at the national level. Another place that UGHE and the Center for Equity and Global Surgery has engaged is in the policy world. So the dean's vision coming in developing global surgery at UGHE included a innovative curriculum for students, starting a residency that was aligned with the College of Surgeons of the region, and also impacting continentally how surgical systems were addressed. So a team of leaders from around the continent, supported by a secretariat at the UGHE, developed PASHIF, the Pan-African Surgical Health Equity Forum, which so far it's been 2 meetings, a meeting in 2023 and a meeting in 2024, which has brought together minister representation from 40 of the 54 countries on the continent. Those are there. In the first round, essentially created a 50-item document that agreed, we think these are the things that are essential to transform surgical care on our continent. And it fits all those 6 pillars: the workforce and the health delivery, the financing, the governance. We need to agree upon this. This past year, the next round was to say, okay, how do we organize that? So they created a board of governance structure, which was a board of governance that takes leaders from all the subregions across the continent, and then a roadmap for how to change things at the national level, at the regional level, i.e. East Africa, West Africa, North, South, and at the continental level. These include things like strengthening our surgical training programs, sharing resources across the region. You're not going to have a pediatric general surgery residency in every single country, 54 of them, but maybe have one or a few in every region. Let's figure out how to share those resources, figuring out visas for patients so they can be transferred from country to country rather than transferred to other continents, which is what often happens. And then at the continental level, working with the AU, the Africa Union, so that this organization eventually is housed within the AU as the major policy body for the continent. So PASHIF, I've sort of got dragged into it, honestly, and I'm usually a fly on the wall in the room. And it is a remarkable moment to observe the continent organizing itself. And I think in this moment that I referenced at the beginning, all the more valuable to see national and continental leaders say, let's figure out for ourselves how we are going to move ourselves forward. We'll bring in partners as we need for innovation, for certain focused efforts, but not for ongoing day-to-day care. Speaking of policy, this is now back to our group in Boston. One of the ways that we've been able to engage with policymakers is by becoming a collaborating center for the World Health Organization. As we know, the World Health Organization is going to be going through some narrowing times, some sort of austere measures. The collaborating centers have always focused on a couple key people at the headquarters in Geneva, and our activities from the PDC are these assessments of where national surgical plans are going around the world, contributing to this compendium of the WHO, which is sort of, if you want to do an appendectomy case, what are the necessary materials and costs and consumables you need at different economic levels. So they're working with lots of partners for that, developing or strengthening their trauma registry, and then creating communities of practice. These are our PDC activities, but in the wake of changing economics for the WHO, something that I didn't see coming, but just has started to happen, is all those collaborating centers which have really been sort of spoken hub to the headquarters, has said, well, okay, headquarters is probably going to shrink. It's not going to disappear, but there's no reason we actually, the collaborating centers can't collaborate with each other rather than just with the headquarters. And so this is happening like now. We have a meeting next week. There are collaborating centers around the world, and instead of all the collaborating centers looking to Geneva, let's strengthen our networks so that lessons learned by the collaborating center in Delhi can be shared with the collaborating center in Africa and other global north areas. So an exciting time. The policy space has not been my personal driver, as I've said with a few friends here. This is, from my perspective, the most exciting moment because we've sort of shifted our gaze from Central Europe to around the world. Coming close to wrapping up. So these future opportunity slides are kind of deliberately fairly Spartan, in part because that's where these programs are, and in part because it's where the present moment is. Again, these are a couple future things that we're at the PDC are looking to do or get more engaged in. The COAST program, Climate and Obstetric Anesthesia and Surgical Surgery Team, we've had it for some time now. It looks to do both, understand both and how to decrease impacts of the way we deliver care. And all of us can close our eyes and see the plastic bags, clear and red at the end of an operative case that we all do. We probably all have some discomfort, some distaste for it, and it feels overwhelming to try to figure out how to make that better, how to decrease the amount of trash, decrease the amount of incineration, the energy costs of lights always being on in our theaters. So how do we in the global north, particularly the US is the greatest producer of carbon emissions, decrease that impact? And how do we support resilience with partners in global south that are having the greatest impacts? Talked about the earthquakes and the explosions in Myanmar and Iran and the floodings in Rwanda and the droughts in various areas. So climate change experts, and I'm not one, but the climate justice even experts are looking at both of those. It's also a funny time, right? The US has pulled out of the Paris Agreement. In various accords that we as a nation are not supporting. How do we as a program within this nation engage in those? So that's a live question for us. And this slide is also kind of deliberately fairly coarse because this is where we are with this idea. The Navjit Roy, the guy that I mentioned with the fishing parable, he's challenged to say it's really nice to document lots of things and it's nice to have a baseline of evidence, but actually the surgery needs to happen. Right? We all know that COVID created a huge backlog of surgical cases, and that's actually that is a concern that every minister of health will get. Maybe not because they are thinking about the 1 million operations that didn't happen in Nigeria during COVID, but because they have a family member who didn't get her cancer care because hospitals shut down because of COVID. So what can we as a surgical and the global surgical community do to help those ministries? Well, we can figure out our own stuff, figure out how to be more efficient, Saturday operations, shorter turnover times, operative camps, different ways to increase throughput while maintaining quality of surgical care to cut down that operative log or that backlog. And that feels very close to home for us as surgical care experts and providers. So Plus One is a program that we are hoping to roll out with partners in South Africa and then in a few other places, Zambia and Rwanda, but it's at the very beginning stages. I don't know if it'll still look the same, feel the same 3 months from now, much less a year from now, but this idea that we as partners help with the strengthening of implementation for those of us and all of us and sort of academic places where we are pushed for our academic output is an important reminder from friends who are also prophets. So last couple slides. I come back to this National Surgical Plan structure to say for each of us to ask ourselves as individuals or as a group, as a program, as a department, as an institution, where might you engage? As I said, no one group is going to cover all these, and no one person is going to cover all these in a moment, maybe touch them over a lifetime. But there are some wonderful opportunities, even in this present moment, where funds are shrinking, where there's a tendency towards pessimism, to partner with colleagues. Dr. Fong was talking last night about multiple MOUs, memorandums of understandings, with partners in various places, in Vietnam and Ghana and elsewhere. And I think these are essential moments where essentially friendship and engaged relationships working together in the same direction over a long period of time can have impact. So I ask you to look at those and think about it for yourself. My concluding thoughts are from this man, Paul Farmer, who many of you may know about, but not necessarily all. Paul was a humanitarian surgeon, professor at Harvard. It's really started his work in doing solidarity accompaniment work in Haiti. Passed away 3 years ago, and lots and lots of quotes. He's an anthropologist, wrote big fat books that are really dense to read. But as a person, was sort of a prophet in his time. And so I'll leave us with this. With rare exceptions, all of your most important achievements on this planet will come from working with others, or in a word, partnership. So with that, thank you for the opportunity to be here to spend this morning with you and really this whole rest of the day. Thank you. Want to do questions and discussion now, or how you normally do this? Yes, sir.
Thank you so much for coming here and delivering this lecture and helping us with our organization of our thoughts and plans for our global surgery program. So, you know, we often have this view, and I know you don't, but, you know, we need to go to these other countries and teach them, you know, how to deliver healthcare. I would argue, and you would, in a similar fashion, that they actually have perhaps more to teach us in terms of how they actually get, in some countries, relatively good healthcare for, you know, 1/20th of the price we spend per capita. And, you know, as you help these countries, I'm sure the goal is not to develop a health system that looks exactly like ours. I think that would be a mistake, because we have a lot of issues with our healthcare delivery system. So what are your thoughts on that, and what can we learn from them?
Thank you, Dr. Schulich. 110,000% agree. It's not uncommon, it's not unnatural to have this sort of sense of we are going there to help them, right? We have the passport power and the US dollars and all those things. And so I think it is a deliberate effort to generate some humility, to spend more time listening than talking, and to look around. You know, the old proverb that we're given 2 eyes, 2 ears, only 1 mouth. There's probably a reason for that. Is very apropos for these partnership situations. I think there is, the framework has to be, and that was that sort of partnership framework, there has to be a sense of mutuality, that we are, all actors in the space are learning together. We are co-learners, we're co-implementers. And I think with that, there can be this moment of wonder and or surprise. A few examples. A bunch of years ago, maybe 2012 or so, the head of the hospitals across that valley in this photo, that the foreground is the University of Global Health, across the valley is Taro Level 2 Teaching Hospital. The hospital director, Dr. Tarsis, is he's a military man. Rwandans are pretty closed culturally anyway, and he's military on top of that. So I was always very intimidated of him. But he came to Brigham, or came to Boston for a summer, and he was essentially observing lots of things. And when I met with him again back here in Rwanda, just over lunch, said, "Oh, well, how was your time in Boston?" He lit up. He said, "It was incredible." I said, "Okay," thinking in my head. "I saw healthcare in Rwanda the way it needs to be." And I thought, "Oh no, is my impression. Like we have an MRI on every other floor and CT scan everywhere. And he said, I said, well, what do you mean by that? He said, you there have teaching conference every day at noon. You provide some food to the residents come. Your floors are organized by discipline. In your theaters, you have created teams that are developing specialty care together rather than everybody just continuously rotating around. He saw things that I don't see. He saw systems of practice that would impact his care. So I was surprised by what he saw that I just don't see. So there's that piece of we see things differently because of our lived experience before this. Cameron is about to embark on research to provide evidence base for something that's already known in some practices. Dr. Gibson and I both do burn surgery. Burn surgery in many places around the world is quite neglected and looks very different than it does in a center like here because of the lack of ICUs and blood banks, et cetera. And also because gauze is hard to come by and expensive and just a heavy lift to constantly change it. But in some parts of the world, these other things like banana leaves as a low cost, obviously environmentally reproduced, non-stick topical coverage. And then also honey as an antimicrobial because of the oxygen-free radicals releases. So there's an opportunity in Rwanda to study that. But there's also the opportunity to integrate that into our cost-heavy and trash-heavy systems around the world. There's a mutuality there that we can find. There's also creativity for us as surgeons. There's creativity for how do you engage in this problem. And I can go back to lessons I've learned from non-surgeon healthcare providers in Angola and in Nigeria and in Rwanda that, I do some things differently. I approach that giant, I don't do prostatectomies in the US, but in other places have. I approach exposure differently, and I refer to so-and-so and so-and-so for these. So we all stand to gain. Dr. Nguyen we were talking last night about plastic surgery lead in Hanoi, and I try to remember the volume of you're telling me of the hospital, 2,600 bed hospital with so much facial trauma that they're doing microscope cases around the clock. There are definitely systems of practice and systems of movement and even the elegance of economy of motion that we can learn without the predatory, I'm sending my residents there to learn open surgery because we only do laparoscopic robotic. We have to guard ourselves against that. But 100%, I think that there's a mutuality that is not only necessary in these partnerships, but is some of the most fun part of these kind of partnerships. So.
Thank you.
It's coming on the 8 o'clock hour, so just it's a little late, but yeah, we're coming on the 8 o'clock hour. But I just want to thank Dr. Riviello once again, and I'll also put a plug in. We have an entire day's worth of programming for our Global Surgery Summit. It's going to be over at the Krugman conference room over in RC2. There will be lunch, so definitely if you guys have availability, that would be great. And lastly, I wanted, on behalf of the Department of Surgery, I just want to give you a token of our appreciation for coming here. This is a little swag bag. So thank you so much for coming and enlightening all of us, and look forward to the rest of the day. Thank you.